Good afternoon, everyone, and thank you all for joining us today. As you heard from Julie, I've had the great privilege of being involved with RIZE since the beginning, and I'm honored to be here today and have the opportunity to moderate this panel of amazing colleagues and friends to share their expertise about innovative models to care for people who use drugs, who are experiencing the intersecting harms of COVID and being unhoused. As our hospitals are again full of patients with COVID and our healthcare workforce is stretched to creatively meet the needs of our most vulnerable patients, particularly amidst an ongoing surging overdose crisis, this panel could not be timelier. In addition, as we just heard, as we talk about intersectionality today, we must also talk about the harms of racism. The health impact of living in a racist society has been laid bare, both in terms of the overdose crisis and COVID-19. And we've seen a terrifying and brutal display of white supremacy in recent days in our nation's capital. Today, our three panelists will each share for about 10 minutes or so about these incredible programs that they've helped lead and design in this moment of crisis. And then we'll have time for what I hope will be an interactive discussion. So I'm going to ask that you please use the Q&A function on Zoom to ask questions as the panelists are speaking. And then I'll try to collate those and feed them back so that everyone's voice can be heard as we get to the discussion period. Now, without further ado, I'm delighted to introduce Dr. Miriam Komaromy, who's Medical Director of the Grayken Center for Addiction at Boston Medical Center. She'll be followed by Dr. Denise de las Nueces, Medical Director of Boston's Healthcare for the Homeless program, and then Dr. Traci Green, who's Professor and Director of the Opioid Policy Research Collaborative at Brandeis University. So with that, I'll turn it over to Dr. Komaromy. Thank you so much. Dr. Komaromy, I think you may still be muted.
Sorry, can you hear me now? It sounds like I was double muted.
Yes, that's perfect. We hear you.
Okay, fabulous. Excellent. Thank you so much, Dr. Wakeman, for that lovely introduction. And thank you to RIZE and to BSAS for the support that allowed us to put in place the program that I'm going to be telling you about. RIZE has funded us to do some writing about the work that we've done at the East Newton Pavilion, developing the COVID recuperation unit. And it's been exciting to pull together the information that we've gathered through that experience. So at Boston Medical Center, we have been serving as a safety net hospital for Boston for about 150 years. And in that role, we early on became quite concerned about the fate of our many patients who are experiencing homelessness, who we knew would be at high risk of infection with COVID, development of the COVID illness. And we became more and more convinced that we should get involved in providing some sort of safe recuperation space and clinical support for people who are infected with COVID and experiencing homelessness. But we didn't do this in a vacuum. Over last winter, fairly early on in the winter, we started joining calls that were convened by the Boston Public Health Commission that were focused on pulling together organizations working in our neighborhood that served people experiencing homelessness and trying to problem solve around these issues. What were we going to do to help support these patients as they became at risk for getting infected? So if you or I became infected with COVID and weren't violently ill, we would be told to go home and have our loved ones care for us and recuperate at home unless our illness violently worsened. And of course, that's not an option for someone who doesn't have a home. And so this was sort of the conundrum of what can we do if someone is not sick enough to need hospitalization, but also doesn't have a safe place to recuperate. Right next to the BMC campus is the East Newton Pavilion, which was actually until recently part of BMC, but now belongs to the Commonwealth. And in conversations with this group pulled together by the Boston Public Health Commission, which included folks from Boston Healthcare for the Homeless, the Boston Public Health Commission, shelter leaders, and harm reduction specialists, among others, we agreed that it would be helpful if BMC could figure out a way to try to meet this need. I and others who were joining those meetings started speaking with Kate Walsh and other leaders of our organization and expressing concern about this. And some leaders within the organization expressed a reasonable concern that, hey, we're going to need all of our providers and staff on site to care for patients who are in our hospital units, the ICU and the wards. We're not going to have extra personnel to help to support other efforts. But I must say, our CEO, Kate Walsh, had a real vision about our need to think outside the box of our hospital and think about how we could stretch and provide support to folks who were not hospitalized at BMC. And so she approached the Commonwealth, and the Commonwealth agreed to loan us back the space in East Newton Pavilion. So next slide, please. Over a very short period of time, in fact, 2 weeks from when we got permission to open the unit until we actually opened, we implemented a COVID recuperation unit within the East Newton Pavilion. This was something called bedded outpatient care. Patients stayed overnight and in fact were confined to the unit for purposes of infection isolation, preventing the spread of infection, but it was not a hospital unit. Instead, there were medical staff and nursing staff on site 24/7, but we didn't have the capacity, for instance, to intubate patients or run a full code or a lot of other functions that are available in a full-fledged hospital. We, as I mentioned, launched within 2 weeks of receiving the loan of the building, and that was through tremendous collaboration among different parts of our hospital, as well as external partners. So we had a great deal of the equipment that we needed donated. All of the furniture, the food was delivered on a daily basis to our patients as a donation, clothing, hygiene items, et cetera. And the units within the hospital, security, the housekeeping, nursing, pharmacy all came together. The staffing was provided primarily through furloughed medical staff and BMC physician volunteers, as well as some contracted physicians. And we included counselors and harm reduction specialists from the beginning. Next slide, please. The patients who we admitted, and we cared for 226 patients over an 8-week period. They stayed for an average of almost 8 days each. The patients had very high rates of comorbidity in addition to their COVID infection. Almost 80% of the patients who we admitted had a co-occurring mental health diagnosis. You can see the diagnoses displayed here. And more than 40% reported that they were actively using substances at the time of admission, with alcohol being the most common substance, along with opioids and cocaine, but a wide variety of substances. And tobacco is not included here. The vast majority of patients did use tobacco at the time of admission. Next slide, please. About half of the patients we served were non-white, and 74% were male. So what did we accomplish? The COVID recuperation clearly helped to avoid exceeding hospital bed capacity during the epidemic surge. BMC had a higher percentage of our patients being COVID infected patients than any other hospital in the city. And our hospital was teetering on the edge of exceeding our capacity during that early spring surge of last year. And the fact that we could triage patients who had come into our emergency department with COVID infection to this safe place to recuperate under medical supervision rather than admitting them to the hospital made a critical difference. I'm also happy to report that there were no deaths in the unit. All of the patients who came into the unit were homeless at the time of admission, but about a quarter of them we succeeded in not discharging back to the street or shelter, but instead we were able to place them with family or in residential treatment programs at the time of discharge. 5% of patients did develop serious complications and were transferred to BMC, and it was very reassuring to have the hospital emergency department just 2 blocks away from East Newton Pavilion. We did have, I think, 7 or 8 patients who experienced an overdose during the time that they were in the facility, and fortunately, all of them were successfully reversed. Next slide. So we obviously had to contend with some pretty significant substance use disorder issues. One being frequent withdrawal. When patients who are actively using substances are plucked unexpectedly out of their native environment, they may or may not have been seeking treatment or in treatment for their substance use disorder, and so withdrawal was very common, and we had assessment and treatment available 24/7. Also, patients came in with very complicated SUD, substance use disorder, and behavioral health issues, and so we had availability of addiction consultation using video technology from the addiction specialists in our hospital to our COVID recuperation unit. We prescribed a lot of buprenorphine to patients coming in the door with opioid use disorder, but there were also some patients for whom buprenorphine was not an acceptable treatment, either because they had been using medications that would interact with the buprenorphine, such as methadone, or because they preferred methadone as a medication treatment for opioid use disorder. We initially obtained methadone by a take-home supply for patients who are enrolled in OTPs, but we also wanted to be able to start patients newly on methadone. And in meetings with the DEA and our inpatient pharmacy leadership, we were actually able to obtain permission to do new starts on methadone and to dose patients in our unit, which was exciting and positive development. We had a major focus on harm reduction to try to help patients to stay safe, even if they continued to use drugs. This was complicated because it was a hospital unit. I mean, it looked like a hospital unit, even if it wasn't a full-fledged hospital, and we did have presence of security. It also meant that there was debate around the advisability of providing safe injection supplies at the time of admission, and we ultimately compromised on offering patients harm reduction supplies at the time of discharge. Next slide. So my last slide is just to mention some pros and cons of this model. Favoring the model, we were, I think, quite successful at preventing spread of infection. Patients, once they came into the unit, were expected to stay in the unit. A few patients did decide to leave against medical advice, and some of them returned. But in general, we tried to discourage this, and we tried to medicate patients and provide counseling to help patients to be able to tolerate staying in the unit. This meant that they were not infecting other people. Our staff all wore full PPE, and the patients did not have to while they were in the hospital. We were also able to meet complex needs and treat substance use disorders and behavioral health issues effectively, and we're particularly proud of the ability to prescribe methadone, to dispense methadone. We had no deaths. We were successful in reversing overdoses, as well as having easy access to the BMC, ED, and higher levels of care. On the downside, as I mentioned, harm reduction was quite difficult to implement in this setting, and there was a lot of conflict among the staff about what harm reduction meant in this setting. Patients were not able to come and go, largely because of concerns about infection, but this also complicated what harm reduction means under these circumstances. The presence of security on site was challenging, as there was a considerable culture clash between the security personnel who were staffing the unit and the harm reduction goals. But it wasn't just with security staff, it was other members of the staff as well who questioned how we were approaching this. And finally, some patients did not need the level of medical intervention that we offered, and it seems to me it would be prudent to consider offering a mixed model with both medically, clinically based care and also a hotel-based option, as you'll hear about in the next presentation. Thank you.
Thank you so much, Dr. Komaromy. We're going to take all questions at the end, so thank you for those who have put some into the Q&A. And I'm going to next invite Dr. De Las Nueces to talk to us about the model at Boston Healthcare for the Homeless program.
Thank you so much, Dr. Wakeman, and thank you all for the incredible honor of being part of this panel today. I know I have just 10 short minutes, so I will dive right into discussing the COVID care models that we designed at Healthcare for the Homeless program. For those of you who are not familiar with BHHP, I just want to give a brief overview that we are a federally qualified community health center that has been around since 1985. With the singular mission to provide or assure access to the highest quality healthcare for homeless individuals and families in Boston. If you go on to the next slide, you will see kindly that we, over the past 35 years or so, we've built a really extensive and far-flung footprint here in the city of Boston and even beyond. Most of these 40 or so sites where we have a clinical presence are actually shelters. And a few of them are actually treatment programs as well. Next slide, please. What we recognized really early on, in particular back in the first surge, is that despite all of that infrastructure that we built over the course of the past 35 years or so, because of the exquisite vulnerabilities of our patients and also because of the need to rapidly design isolation and quarantine spaces, that we were going to have to very quickly redesign our service delivery. And in doing so, we kept the following assumptions in mind. First, that our patients are and were at the time highly vulnerable to COVID-19 infection and its complications, largely because of the high prevalence of tri-morbid disease. Dr. Komaromy mentioned this in her own presentation, but there is a very high prevalence of chronic medical, behavioral health, and substance use disorders among the patients who we serve at Healthcare for the Homeless program. We recognize as well that our patients have very little ability to socially distance, whether they are staying in congregate shelter settings or in crowded encampments outdoors. And there's also recognition of the fact that our patients engage in behaviors that often increase the risk of transmission via respiratory droplets, such as sharing of cigarettes. And so there was this really great urgency that we felt in the beginning to create new isolation and quarantine spaces for people without homes or those who can't safely isolate. And we did so in partnership, of course, with the City of Boston, with the Boston Public Health Commission, with BMC, and others. And throughout the entire process, as we were considering how to design and actually operationalizing the care models that we ultimately engaged in, we recognized that we could not lose sight of patients' behavioral health and harm reduction needs in the process of quickly designing these new services. Next slide, please. So what I'd like to really briefly introduce to you all today are three distinct models of isolation space that we designed at Healthcare for the Homeless program, of course, with lots of support from several partners, as I mentioned. The first being tents, and in particular our isolation and quarantine tents. So think no existing infrastructure and the need to really rapidly erect, in particular in the very early part of that first surge in March, really rapidly erect services to help pluck individuals who were symptomatic and could have been COVID positive out of the shelters. From a public health perspective, really trying to minimize the transmission in shelters. Secondly, we tapped into as well for our second model, our existing medical respite facility, which is a 24/7 facility, of which I'll speak a little bit more later, but had incredible existing infrastructure. And just our goal and our task at the time was really adapting that infrastructure to COVID care spaces now for individuals experiencing homelessness, and also overlaying, of course, the importance of addiction medicine. And lastly, this massive undertaking, which we engaged in, of course, with the City of Boston, of operationalizing a field hospital at the Boston Convention Center for individuals experiencing homelessness who are COVID positive. Underlying all of these three models of care was a commitment to harm reduction at every step of the way. Next slide, please. So first, turning to the isolation and quarantine tents, as a reminder, the isolation tents were designed for individuals who, and this is again in the very beginning of the pandemic, individuals who were shelter bound or staying in crowded encampments who had symptoms highly consistent with COVID, who were awaiting confirmatory test results and awaiting placement at a long-term isolation facility, but who needed to be outside of those crowded shelter settings while they awaited the results of the testing, and of course needed to be isolated. And then the quarantine tents were designed specifically for individuals who, again, were shelter bound and who had been identified as close contacts of confirmed cases of COVID. You'll see here that the tents were erected in a space that was co-located with the largest men's shelter here in the city of Boston. Notably, I just like to, when I look at this slide and present it, I just want to draw your attention to how much space there was outdoors. And what this meant is that people who stayed in these isolation and quarantine tents, although there were really strict parameters, of course, around not leaving the grounds, they could still, they were still allowed 1 hour a day to come outside, again, not leave the grounds, remain in the space where they were not in contact with anyone outside of PPE or anyone in the general public, but attend to their care needs in whatever way, in whatever way that meant, whether that was engaging in needed drug use or the like. But they did have that flexibility, which we really didn't have it in any of the other two care models. And because of that, I think we were really successful in taking care of a total of 260 unique patients from March through May of 2020. If you go on to the next slide, kindly, you will see walking inside of the tents, you'll see on the left-hand side, each individual was given a cubby or a pod, but within those pods on the right-hand side, you'll see that we really tried as much as we can to design the space with the patient's experience in mind. So there was access to electricity where people could charge their devices, could have access to Wi-Fi, to watching entertainment as much as possible to help them be as entertained as they could be during this isolation period. And then also a locked cubby, as you see here on the right-hand side as well, again, just so that they could keep whatever belongings that they had on their person safe, with the exception, of course, of weapons. If you go on to the next slide, kindly. You'll see here that we tried in earnest to apply our BHHP model to this tent medicine model. We created standardized workflows for providers, nurses, and case managers who were on site. We, of course, focused on management of COVID-19, but there was great attention to comorbidities, including substance use disorders. And so we worked collaboratively with our BHHP behavioral health and OBAT teams. They had a presence either on site in PPE or via telemedicine, so that patients had that access. There was on-site access to medications into a pharmacy, despite the fact that this was a tent. So we were able to utilize buprenorphine, benzos for management of withdrawal symptoms. And again, there was that embrace of low threshold and harm reduction models of care. I mentioned before the fact that each individual was granted at least an hour a day when they can go outside of the tent, but stay within the grounds to care for their needs. And if you go on to the next slide, you'll see as well that we included milieu managers and runners in the list of staffing who are on site. And these two disciplines in particular had the task of coordinating methadone take-home doses, of coordinating safe transport of individuals who were in these tents to nearby methadone clinics, which were not far away as well, which also incredibly helped with our retention efforts. If you go on to the next slide, kindly, you'll see here, again, just an application of our mission to this tent medicine work. On the right-hand side is a little picture that one of our patients drew for us very early on, thanking us for the experience, and in particular just stating that despite the fact that they were had to isolate or remain in quarantine for these days, that there was an attention again to trust, respect, dignified care, and hope for our patients. If we go on to the next slide kindly, I'll talk briefly about our second care model, which is the Barbara McInnis House, or BMH COVID ward. For those of you who are not familiar with BMH, it is a 104-bed medical respite facility that's run by a program that's been around for more than 20 years. It provides 24/7 medical and recuperative care for individuals experiencing homelessness with acute medical needs. So individuals who are too sick to be in shelters but don't have an acute illness such that they need to be hospitalized. We were able to successfully convert a full ward, so 50 beds of the McInnis House, into a COVID ward, and cared for a total of 242 unique patients in that first surge. And this model was actually the easiest of the three because we already had an existing infrastructure in place to care for individuals struggling with substance use disorders at the McInnis House. And we were easily able to just adapt that infrastructure into the COVID-19 care. And that infrastructure included X-waiver prescribers, protocols for use of buprenorphine and benzos for management of withdrawal symptoms, 24-hour nursing care with expertise in the management of withdrawal symptoms, behavioral health specialists, and case management services well-versed in treatment programs as discharge options. If we go on to the next slide kindly, I just will briefly introduce to you all our third and last model, a healthcare for the homeless program, which is the Boston Hope Field Hospital. As a reminder, this was a 500-bed field hospital at the Boston Convention Center. We worked with the city of Boston to provide the clinical services. We cared for a total of about 307 unique patients at Boston Hope during that first surge. And again, we were really centered, or we kept harm reduction and trauma centeredness at the forefront throughout the operationalization of this model. If you go on to the next slide kindly, you'll see here that one new discipline that we incorporated into the staff in Boston Hope was harm reduction specialists, in particular experts in harm reduction from the Boston Public Health Commission's AHOPE program, who provided really incredible and needed support of our patients. Here, this is very different. It was a cavernous space and patients weren't really able to head outside. So we really needed that level of support in terms of improving the patient experience at Boston Hope. If you go on to the next slide kindly, I will just briefly highlight that this is actually from one article that was published in the Lancet Psychiatry last year by some of our psychiatrists, but this highlights the implementation of a mental health disaster response framework that was applied at the Boston Hope Hospital. And I just want to highlight that we really tried our best to incorporate addiction-informed and trauma-informed, culturally diverse workforce or staff. There were recovery groups on site for patients, again, to improve their patient experience and to attend to their SUDS needs. And then, of course, a collaborative services connected with harm reduction services. And patients upon discharge were often connected to sober houses and OBAT treatment programs, as well as residential treatment programs. We go on to the next slide kindly. Briefly, just in looking back at our experience, the lessons learned here are very similar to the ones that Dr. K, presented. Integration of behavioral health, addiction, medicine, harm reduction, and recovery supports being crucial at every step of the way, and particularly provision of medications for management of withdrawal symptoms, improving retention and patient experience. So I will stop there because I believe I am out of time, but thank you again for the experience, and I look forward to answering any questions in the Q&A.
Thank you so much, Dr. De Los Nueces. That was amazing. And I'm going to turn it right over to Dr. Green to hear her presentation. And thank you again to people who are putting questions through. Dr. Green.
Thanks so much, Dr. Wakeman. So we were delighted to carry out this evaluation of the state's isolation and recovery sites as part of our work for the Department of Public Health and funded by the Centers for Disease Control and Prevention. So the state isolation recovery spaces also provided homeless individuals who need a safe place to isolate but differed from the models you've been hearing about and seeing from my colleagues in several really important ways. First, they are initiatives of the state, specifically the Commonwealth's COVID-19 Command Center and the Massachusetts Emergency Management Agency, or MEMA, who contracted with the not-for-profit care delivery system Commonwealth Care Alliance to carry out the day-to-day operations of the sites. So these are regional isolation and recovery sites that are located in hotels across the state, and then transportation from referring places like hospitals or homeless shelters and treatment programs, even Section 35 units, to the programs, from those programs to the sites were also provided. Next slide. So in this unusual experience, an individual experiencing homelessness who became an infected patient, then transformed into a guest. And guests, as they were called by the staff and all of my research team, not patients or patrons, who stayed at the hotels, were provided their own hotel room, all meals, nurse care and telehealth, behavioral health supports, and other basic needs, including bathrooms, as one of the comments in the Q&A mentioned about, very important. They received the services of hotel guests like housekeeping, laundry, phone, and security, and unique linkages to other state services like Mass Health and SNAP enrollment. Guest stays at the sites ranged from 7 to 20 days, and this is different from municipal sites that may have hosted people for substantially longer, from weeks to months even. And then afterward, and after their recovery, they were expected to return to the community with supported movement from one entity to the other. They also differed from the municipal sites that you've heard about. The state isolation sites did not operate like shelters, and they did not adopt shelter policies. In fact, they are a completely new entity. The guidance and policies that were created by the state, provided by the state, focused on the needs of the guest, and that is what really those accommodations and services that were needed for the guests, encouraging safe and completed home isolation stays, harm reduction, and guest-centered care. So for example, there were no random room or bag checks as might happen in a shelter environment. This is very different, so a safe space of one's own. So re-envisioning the guest and host partnership in these settings is really embodied in a phrase from the intake guest letter that's provided to people: "We need your help to best help you." So recognizing that guests may have problems with substance use, and this may be a key driver of breaking isolation, the state's guidance took a harm reduction approach decidedly. This included ensuring local harm reduction organizations access to the isolation recovery sites. If you could hit the animation, this would be helpful on this slide. Thank you. Informing the guests from the get-go of the availability of services and supplies, adopting high tolerance for alcohol and drug use on site, and encouraging in-room safe use and communications for safety checks if people wanted or needed them. And then training site medical staff in the adoption of harm reduction in nursing care and inviting its practice. And site visits by advisors to check on this aspect of the sites from external state partners. And rather than like bold policies or written statements, this harm reduction approach used symbolic and coded gestures like low barrier buprenorphine, telehealth, naloxone and visible spaces on site, ready offers of withdrawal support upon arrival, and really knowing about the site and their operations in this way relied upon word of mouth in the community rather than advertisements and heavy outreach to referring hospitals and organizations, at least how we evaluated us. So the next slide just conveys what we did. Really, our rapid assessment evaluation was carried out over a 3-month period of time, and our job was to obtain feedback on guest service utilization, their stay experience at the state sites, and also to contrast that with people who had stayed in municipal isolation sites. To understand how guests experienced their active drug or alcohol use during their stay, and then look at how the awareness and experience of people who have behavioral health and harm reduction services taken in, how that was integrated into their care environment and their state. And then to learn how their stay may change their use, their recovery, and their housing trajectories. And we did that by surveying and interviewing 50 guests during that short period of time. So 26 came from the isolation recovery sites, and all sites at the time that were in operation, 5 were represented in our interviews. And then 24 from different, 24 participants from municipal guests who stayed in Methuen, Cambridge, North Andover, Taunton, Boston Hope, and Boston Best Western. So the next slide gives you a little bit of a snapshot of who our folks were. So guests had a broad range of ages represented, with most guests being older than 45. The isolation recovery site participants that we spoke with, the guests we spoke with, appeared to be, the sites appeared to host younger guests compared to the municipal sites who tended to host older guests. The guests were predominantly male. 64% were of white race and 24% were of Hispanic and Latinx descent. All of the individuals at the state site were COVID-19 positive. 62% across the board of our participants we spoke with had received the first stimulus check. A sizable number of the guests were employed, and about half had ever been incarcerated. But the next slide also reflects some of the guests' substance use histories, and in particular, lifetime history of drug use, including marijuana, was high. 88% of the people we spoke with, and many were actively using. So about half used alcohol or drugs, and 24% were actively using illicit drugs other than marijuana. So some guests in the state and municipal sites reported use of drugs by injection. They used drugs in public, and many had experienced or witnessed an overdose. About 1 in 5 had experienced Section 35 or civil commitment, and 1 in 4 were currently taking medications for opioid use disorder. Thus, guests generally are an affected group with important substance use related health needs, and in the hotels, COVID-19 health needs. The next slide. So there are many insights gleaned from the evaluation. I'll just highlight a few here. One key theme was the hotels as a place of healing. Guests at the state isolation recovery sites really conveyed that their stay at the hotels provided a window of opportunity to address social determinants of health, where their basic and medical needs were met, where positive therapeutic connections with nurses and the nurse teams were extremely important. Those relationships were forged and nurtured over a concentrated time. The provision of a safe, private space to sleep, to heal, and to truly recover mind, body, and spirit was greatly valued. COVID-19 brought unprecedented fear and stress, especially for people who were homeless and unstably housed, both for themselves and for the families and others that they were caring for and who may have depended on them. The contrasting experience at the hotel really conveyed safety and dignity to the guests, and the quotes here really well illustrate that. A female guest in the Everett site conveyed really that I feel good that I'm in a safe place. I feel good that I'm getting medical treatment. And if I felt sick, I felt good that you would, take care of me or do the proper examination, and you know where to send me and where I need proper treatment if I had any problems that get exacerbated. So I felt good about this place. And a male guest in Northampton reflected, well, there's the notion of the teamwork that the staff has for you, and the fact that if I need something from the outside, they'll go out and buy it for me. This is a very important aspect of the guests who were, especially people who were using actively in their substance use. They very much depended on the staff to help them for access, especially to alcohol and to tobacco. Everyone's respectful, and I have dignity about myself. I stay to myself. I just want to stay cool in this room. And so I'm enjoying every second that I can be here, because I have to make the best of it, And I can't pinpoint it, but a combination of everything, even if something as fundamental as on a hot day having an air conditioner, or when he's bored to have a TV. The next slide also highlighted some of those behavioral health considerations that we heard from people. And this is another prominent theme, and where the states and locations really stood out and were different from municipal sites, which had to leverage local resources for behavioral health and harm reduction. But in particular, the state sites drew from federal projects, for instance, the Project for Assistance and Transition for Homelessness, telecounseling, telepsychiatry, and remote recovery coaching to support guests who are looking for or even already receiving these services. So there was continuity of care. And because of the changes of DEA and SAMHSA, telemedicine services for buprenorphine induction and maintenance were available and utilized, thanks to the phones that were available in room. And so you can see from 2 quotes from the 2 females in different sites and isolation recovery sites, the opportunity to hear about and have access to supports in the form of nurses and also the provision of Suboxone. Next slide. So the sites were not without challenge. Guests and staff indicated low awareness of isolation recovery site availability from other institutions. So hearing about the availability of these sites was tricky. Though EMS could have referred and hospitals could have referred, we still heard from guests who found out circuitously through calling 211 or something else, even when they were in a hospital, COVID positive and infected, thinking about where they were going to go next and unable to safely isolate. Methadone provision at the sites could be made smoother, similar to what you heard from Dr. Komaromy. And then transportation to the sites was really by sheriff vans. And that was because there were no other transportation agencies at the time willing to transport COVID positive individuals. So when that lack occurs, the state steps in. So rightfully and appropriately, law enforcement came to help, but that sent a different kind of message for the guests who were there. And while medical staff were trained, non-medical staff like security and other site staff could really benefit from training and guidance on site philosophy about harm reduction and about orientation to safely isolating and the recuperative aspect of these recovery sites. Finally, ongoing housing challenges were evident. And so next step plans were more likely to occur in a state environment than a municipal environment. But things like what you heard from Dr. Calvert on the new Housing First funds could not be greater received than at this time. A transition from an isolation recovery site to a Housing First model is crucial. The next slide. Just to highlight some of the key findings, aside from those key themes, some of the findings that we had for big picture take homes are important here. First, guests really appreciated that time, space, and care to recover. And importantly, I think hearing from people, they felt that they were part of something that was much larger than themselves by taking the time to isolate and be in these hotel spaces, that they were truly recovering, but they were also being part of they were helping their community by isolating, and being part of that larger service was very important to across the board to the guest. Secondly, the current substance use is prominent among guests, and so thinking along lines of harm reduction and treatment and behavioral supports for state sites as well as municipal locations, like you've heard, is really important. The third was that overall, the state sites appeared to better balance the medical and other behavioral health needs, as well as the social service connections. And this was really important because not everybody staying at the hotels were actively using drugs, but there was a high degree of awareness among people who were using drugs without disrupting services for people who were not using. So we had a balance of provision of care and support, but really attentiveness to the people who were extremely vulnerable. Sites were also able to connect people to housing and other benefits during their stay and to maintain medications for opioid use, though it was trickier to start people on medications. A visitor policy allowed people to have access to drugs for guests who were continuing to use, and higher staff tolerance and support for purchases was really critical in this space. On-site naloxone for people who were at risk, and potentially other harm reduction supplies as they came in. Knowledge and accessibility and stocking on site could be improved. Generally speaking, the opportunities to incorporate peer supports are an untapped resource, and thinking about conveying to people who are actively using to better prepare for their arrival, whether that's stocking up or thinking about how recognizing that people to cope we need to find better ways of humane, dignified coping with unusual times and stresses like the guests were experiencing, including safer substance use. This quote from the male in the Everett site was really special. I think we always ask people, is there anything else you want to tell us or the state about your experience? And he really conveyed so eloquently. I'd like to thank them for having a place like this to help people, especially homeless people, who don't have any money and who don't have any family to look to for help. Thank you for, putting me in a comfortable room around good people that seem to mostly care, and where I'm able to be comfortable and to feel a little better. And I mean, this is the happiest me and my wife's been in a long time. So I'm very thankful for that. So yeah, just thankful. And hopefully they'll open up more places like this around the country for people, so they have a place to stay, because it's not getting any better anytime soon. The last closing thought, just in the next slide, was really from our own reflections on this evaluation, some unexpected additional findings. The first one really being that these spaces reflected a clear demonstration that a harm reduction or even a consumption space with medical supervision by nurses can work and actually even coexist alongside people who are actively using and not, much like maybe we see in other communities or even perhaps our own someday. But this harm reduction consumption space approach was clearly an interesting pilot that actually appeared to be quite functional, with 0 overdoses on site, despite over 1,000 guests across the state's isolation recovery sites. And then secondly, taking this opportunity of pandemic and the pandemic setting as an opportunity that sometimes the hardest time to think about making a change is in an environment that's extremely stressed. However, it is potentially the best time to make life changes, and especially ones that are open for wellness. And so thinking about this safe private space for healing that opens the door for other opportunities. And we see this as, we collectively saw this, and I think the guests saw this as an opportunity to do something big and different in their lives. So thank you, and look forward to discussion.
Thank you all so much. That was incredible and rich. And I know we're running short on time for discussion, but I think amazing to get all of those details. And as I understand it, the slides will be shared with everyone. And I would expect that all 3 of our amazing presenters would be open to future conversation as well. A lot of great questions came into the chat. So I'm going to address a few of them in the time that we have remaining. I think I'll start, Dr. Komaromy, with you. There was a question really related to some of the philosophical challenges around harm reduction that you alluded to, particularly in some ways your space was the most akin to a hospital-based space or a very medical model. And one of the questions was related to stakeholder engagement and how, when we know there's so much evidence around harm reduction interventions like safer injection supply and equipment, why is there still so much opposition? Are there any lessons learned about how to engage sort of a broad coalition of stakeholders around this in a medical setting?
Thanks, Dr. Wakeman. Yeah, and I thought that was an excellent question. I saw it in the chat. Yeah, you know, I think that, let's see, are you able to hear me okay? Okay. I think when we implemented this unit, we were probably somewhat naive about that it would be relatively straightforward to have a pretty full-fledged harm reduction environment in this setting. In fact, the people who were staffing this unit were security from the hospital, administrators from the hospital, staff who were pulled, furloughed staff who were pulled from all kinds of units, you know, the ophthalmology clerk and the dermatology nurse and so on and so forth. So there was no real major training opportunity. We got up and running in 2 weeks' time and didn't have a cohesive sense of a group philosophy or approach. We did do some training up front, but the time was limited and it was definitely crisis environment. And, you know, the reality, I think, is that a lot of people, even in an environment like Boston Medical Center, a lot of staff and providers are not fully bought into a harm reduction approach to these issues. There's a lot of stigma around drug use, a lot of lack of understanding of why people use drugs or continue to use drugs. And so there was a substantial portion of staff who felt uncomfortable with these approaches. We initially intended that, as Dr. de las Nueces mentioned, that the only thing that would be prohibited was weapons, but security was, you know, admitting patients at all hours and were searching their belongings often and were confiscating substances. And the challenge between, you know, the biggest challenge sort of structurally on how to really implement fully a harm reduction approach was that we really felt it was important to isolate patients so that they didn't infect other people. So we did not allow guests. We didn't allow people to come and go, to bring drugs into the facility or to go out and obtain substances because of infection prevention. But of course, that made it quite challenging for patients to have access to substances. And I think the final issue that really was substantial is that, you know, it is not legal to have a supervised injection facility in this state or this country at the present time. And the administration was very aware of that and was very concerned about the perception that here we are on state property loaned to us. And what is it okay for us to allow or not allow? It's kind of ironic that the state, meantime, was implementing facilities that took much more of a full-fledged harm reduction approach and operated things could have possibly fallen under that rubric in some ways. But you know, this was sort of the position that was being taken by the hospital of trying to be cautious and think about the external appearances as well as what was happening on this property. So I'll stop there. Not easy. It was a really challenging set of issues.
No, thank you. That's very helpful. And my own internal anxiety about time, we actually have till 1:30. So forget that I said that we only have a few minutes. We have lots of minutes for questions. So I'm glad because there are really wonderful questions in the chat. So Dr. De Los Nueces, in keeping with that idea of kind of philosophy and environment, there's a question around how do you think about delivering trauma-informed care in settings that often can be traumatizing? I think you've mentioned in the field hospital setting, there were National Guard deployed there, thinking about people who have immigration concerns or people who use drugs who've been criminalized or have been punished by the criminal legal system. So many of the kind of elements of hospital-based care can be really carceral in some ways. And I think would love to hear your thoughts about how to, as best we can, be trauma-informed in those sort of settings.
Absolutely. No, thank you for the question. It's a really great one. And I have to say, we struggled with the National Guard issue in particular at Boston Hope. We're so incredibly grateful for the support of the National Guard in providing security for the facility. But really quickly on, I think in the beginning, I want to say about 1 week into operationalizing it, we started to admit people from a local residential treatment program that focuses on the Latinx community. And very, very soon after those individuals were admitted, we were hearing from milieu managers and from our staff that many of them just didn't feel safe. And we completely understood it and felt very, very, terribly, honestly, for not having thought about that initially, because we were just operationalizing as quickly as we could. So what we ended up doing, at least in that particular case, was having frank discussions with the security, with the National Guard, and with the head of the National Guard operations at Boston Hope, and explain to them that for lots of reasons, not just the immigration reason, but also for the fact that many of our patients have had bad experiences, of course, with the criminal justice system, that they needed to be as hands-off as possible and let us pull them in or decide when to pull them in. And in fact, they followed suit, and we're so grateful for that. At each step of the way, though, with Boston Hope and also with the tents, what our philosophy for our patients is that this is what's really recommended from a public health perspective. We want to take care of you, and we also need to take care of you need to take care of the community and remove you from your residential treatment program or remove you from your shelter for the time being in order to keep everybody else safe. But our messaging was that this is in no way, shape, or form we will never keep you here against your will. You know, we have all of these supports in place. We had behavioral health supports in place via telehealth, and also, of course, in person at many of our sites. But patients always had the ability to say that they couldn't take it, that it's too much, and that they had to leave. And in those instances, we of course counseled them as much as we could. We strongly urged them to stay, but we ultimately had to respect their wishes, and we would notify the Boston Public Health Commission of anyone who left against medical advice prior to their isolation period elapsing, so that there was at least an attempt to make sure that we understood that the commission knew if they were re-entering or attempting to re-enter a shelter, that we kind of knew where to kind of find them again and make sure that they were not putting others in shelters in particular at risk. But it was really challenging, in particular with the National Guard issue. But again, our retention efforts, I think, speak to the fact that we did it well. We made some missteps, in particular, as I mentioned, with the National Guard in the beginning, but we really quickly rectified it as best as we could.
Thank you. No, that's incredibly helpful. Dr. Green, turning to you next, there's a question that came in around sort of your closing thoughts that one unanticipated finding of your work was that in essence, in some of these hotels, they did provide a safer place for people to use drugs in a semi-supervised setting, and the sky didn't fall, and other people who were also inhabiting the hotels, in many cases, were not even aware of what was going on, and there were no fatal overdoses, and the possible implications that has for supervised consumption sites in this country. The questioner also was hoping you could opine on the notion of safe supply and the broader conversation around advocacy, and if you see a path forward towards either supervised consumption sites and or safe supply in the US, or what steps that would take.
Yeah, great question. And I think, so I can't see completely into the future on all of this, but I think for the question around, as people were there to thought about a safe supply approach, the 24-hour buprenorphine hotline and earlier access to induction was certainly a clear service that was offered to a lot of the patients. We did not track a ton of induction cases, more of people who maintained, and there's a strong emphasis on continuity of care. But you could think of, and especially as we're learning more about fentanyl and how long it as a real risk factor in opioid overdose, and so much of the fentanyl in the opioid supply, that fentanyl staying longer in people's systems, even if they're not in the community and they're staying and isolating in a hotel, the importance of thinking about how to safely do induction. And, in the hotel is a perfect time to potentially engage in something like starting people on with a microdosing approach, or thinking about other bridge doses. So a safe supply, one that may prescribe another medication, an Adderall for a stimulant, or if appropriate, and identified by the nursing staff and others. But then also thinking about providing withdrawal supports and other comfort meds. That was part of the existing protocol. Recognizing that people were staying for a short period of approximately 7 to 20 days. There's a lot that we can do in that period of time to think about a safer supply approach. And I think some of those take-home messages from the experience of the hotel, safe use in a contained space, connecting to nursing staff on call, checking in regularly, naloxone in place, all mimicked the environment of safe consumption spaces and overdose prevention sites. So there's a lot to learn from that. That I'm very hopeful for, both for our own state and hopefully others.
Thank you, Dr. Green. Dr. Komaromy, turning back to you, some people asked questions about what we can take from the lessons learned here in the time of COVID to actually help us better inform substance use disorder services more broadly moving forward. And I wonder if you could reflect on that in terms of some of the flexibility and creative thinking that went into these various models.
Yeah, thank you. Definitely, we had lots of lessons learned. Some things that I think are fairly obvious were that it was really important to address co-occurring behavioral health issues, that it was critical to have counselors on site to be able to work with patients, particularly on trauma and anxiety. People were so stressed out by the pandemic, and trauma is just a fact of life, after effects of trauma. For this patient population, I'd say it's more the rule than the exception in patients experiencing homelessness and folks who have substance use disorders. So we felt very fortunate to have a cadre of experienced and talented clinicians working on site. We also had harm reductionists who did a fantastic job of working with people around their substance use and advocating for them. And along the lines of what Dr. Green was describing, we altered our medication prescribing practices somewhat outside the bounds of what would usually be considered standard practice for treating substance use disorders for patients in the community, because we were focused not so much on promoting recovery per se, but on helping people to tolerate being in their skin during the time they were confined, So we did prescribe stimulants for people who had stimulant use disorder. We prescribed benzodiazepines for people with benzodiazepine use disorder. And we prescribed, I think, probably somewhat higher doses of buprenorphine and than we would have as a starting out of the gate kind of dose, just to help patients stay comfortable and to absolutely minimize, to whatever extent possible, their symptoms that might have caused them to feel the need to leave the facility. So that was one sort of approach that made sense to us and that we were able to do in the context of the setting that we were in. One thing in terms of lessons learned about the substance use issues, you know, obviously, as we heard from the other speakers, not every patient who came into the facility used substances. And so we had a mixed population of people who were withdrawing, were craving, you know, felt the need to use, with people who had never had issues with substances or who were trying not to use substances. And so having everybody together in a large unit was quite challenging, and some, I think, put patients who were trying not to use at risk for using, because they were there all day with people who were using and had substances sometimes available. And we early on debated separating, offering people the option of being in a sort of a unit with patients who didn't have substance use issues, separated from a unit of patients who did. We didn't do that, and in retrospect, it might have been a good idea. We were hesitant because also of the stigma issues, that we didn't, you know, it's sort of, if by your address you're identified as someone who uses substances, that's also a little challenging. But it did create some difficult dynamics that were pretty challenging to address. And I'd say for me, you know, that I guess I came away from the whole experience more convinced than ever that we need to work toward legislation that allows safe consumption sites, supervised injection sites, what are now being called harm reduction sites, to just acknowledge that supervised safe spaces where people can use substances save lives, and are often, you know, an extremely important intervention that we can offer to help reduce deaths from substance use.
Thank you. I think, yeah, clear lesson from really all three presentations was the role of, you know, kindness, welcoming people in and keeping them safe regardless of what stage of active drug use or chaotic drug use or recovery or anywhere in between they might be. Dr. de las Nueces, there were several questions related to people who are unhoused, and in particular people who are rough sleepers or who don't come into shelter, and the particular challenges of thinking about how to engage people in coming into one of these units or being able to tolerate staying for a community of people that really doesn't even come into shelter.
Yeah, so I think in particular with the Barbara McInnis house, and again, because we've had like a footprint in the community for 35 years, and we also have clinics embedded in the shelter sites, and many of the shelter guests at least have had pre-existing, even before COVID, pre-existing relationships with many of our shelter nurses and providers. I think that really helped us not only in engaging folks in these isolation spaces, people who have had familiarity and good experiences, and we hope that that's everybody, but good experiences with our program, felt, I think, a level of relief that we were the ones who were providing the services, again, because of that pre-existing relationship. So that's one thing. In terms of how people who were experiencing homelessness kind of found out about these services, we created a centralized mission control, kind of like admissions of sorts, that received the referrals from hospital partners, from our own clinics, from shelter partners, who were all aware about our services. And then we made the decision about, you know, which facilities patients were best suited for. I will say I did see a question as well in the Q&A about how we decided where people would go and when. A lot of this was dictated, a lot of of the decision about where an individual patient would be isolated, whether it's in a tents or respite or Boston Hope, was all dictated by timing. So right in the beginning of the epidemic, there was an urgency to kind of get isolation and quarantine spaces like opened and identified, and the quickest way to do that, believe it or not, was erecting a tent because all of the, Boston Hope hadn't yet been even like a thought in anyone's mind yet at that point in the epidemic. And then the McInnis House had existing infrastructure that we really needed some time to adapt to COVID care, and so it was much easier to build the infrastructure in a tent. So in the beginning of the epidemic, folks were shuttled into the tent. And that was our resource while we readied the other spaces. Once the McInnis House COVID ward was operationalized, and certainly once Boston Hope was operationalized, the decision point then was, well, patients would be referred again to our admission control, and we made the decision based on medical need. So who had comorbidities that we feared would render their course of COVID-19 much more complicated, who needed the on-site medical, the more comprehensive on-site medical nursing care. And for those individuals, we tended to send them to the McInnis House in particular because of the proximity to BMC, to the hospital, so that if they decompensated rapidly, we would be able to transfer them quickly. Whereas individuals who are younger, who we suspected would have far less complicated courses, were sent over to Boston Hope. And then at times we did offer people kind of like a menu of options. Here's Boston Hope, here's respite. And there were folks who actually preferred to go to Boston Hope because of the fact that they believed that it would be just a less of a hospital feel and more of a cavernous space. The way that we described it, it felt much more welcoming than the McInnis House kind of like respite facility did. And that was for several people who had experience in the past, may have had experience in the past with the McInnis House. So that's all how we factored in. But people learned about our facilities through our existing infrastructure in the shelters, our existing connection with Boston Medical Center, MGH, other hospitals. That's how it was disseminated.
Great, thank you, Dr. Nueces. Dr. Green, a couple questions came in for you. I'm going to maybe pose a two-part question. The first is around whether you use specifically trained harm reduction outreach workers versus training up people who are working in the hotel space who maybe weren't from a harm reduction background, and what the approach was that the state and municipal sites had around that. And then to tag on to that, was there any sort of way of monitoring for overdose or creating more of a supervised setting for people who are perhaps using alone in their hotel rooms, in terms of some of the lessons learned that could be applied to a supervised consumption site pilot?
Yeah, great. Thanks for the awesome question. So the first is thinking about the staffing. So as the evaluator, we sort of looked and understood as many of the sites as possible, but because they were all organized and their day-to-day functions went through the the Commonwealth Care Alliance, they were organized and contracted through that organization, which did a phenomenal job in the delivery system approaches here. But all of the staff then were nurses who were, for instance, on the medical side, were folks who were contracted through CCA and provided those services. So they may have been folks who were furloughed, people who came from other areas, people working looking for additional hours and had expertise and willing to provide these services on this site for these particular times. So in that environment, the kinds of trainings that were available were through accessible services like the PATH trainings, the organization that provides already homeless services for comorbid conditions and co-occurring substance use and severe mental illness. So the PATH trainings are around like a primer on harm reduction 101 sort of thing, or motivational interviewing and skills and trauma-informed care, and even extensive training on PPE, donning everything that needed to happen in those in particular environments. So there were a number of trainings that happened. But then I think the informal trainings were also really important. So creating a culture of tolerance in this space, everything from the guidance and policies that happen to be interpreted through the leadership and conveyed through the management style. Really the focus is stay. Get patients to stay. Treat them like patients, treat them like guests. Most importantly, they are your guests. Honor their space, honor their wishes, and creating that culture of tolerance and maintaining that culture of tolerance through those policies. The third was, I think, really thinking about external partners who are harm reduction experts. This whole thing really happened by walking into Mana Community Health Center and seeing their team going out and providing naloxone and other harm reduction services to the municipal site, as well as the Taunton Isolation Recovery site, in a kind of a menu of what would you like today? These are the things we can offer. Let us know. Put it under the door, finding out about those services. Brilliant. And then delivering those services in a package, a care package, unique to that individual and behind that door in that guest space. It doesn't get more guest centered. It's awesome. And from that, understanding that culture and that they deserve all aspects of their care, including all harm reduction services to be provided as during their stay. So I think creating an opportunity to learn about harm reduction service provision as healthcare provision and to equate those services, set another kind of tone and notice to the staff that this was important. And then the fourth thing was really thinking about feedback loops. So I am a feedback loop. I'm an evaluator independent. They let us in. They let us talk with their patients, their guests, and observe this experience through the eyes of the people who receive these services, and to collectively bring this back. And good, as we've learned from all of RIZE projects, I think, and programs, is that harm reduction is hard. You know, it requires some caretaking and constant monitoring and feedback loops that are independent otherwise. And that is an important aspect of, I think, what was working here. And I forgot the last other question, which I think was important too, but
the last question was around
monitoring for ODs. Yes, there were a couple different policies that were in place, and then notifications to guests as they came in that if they were going to be using to keep the door unlocked, and that would be a way for them to, if they were going to check on them, and then other ways, never use alone. A functional website for maintaining observed use is another way. And then other technologies and other approaches that we talked with staff and some guests about are perfectly open, I think, for feedback too. But a couple of those things were informal, where nursing staff would come and check 3 or 4 times a day on a patient guest. And so there's a sort of built-in monitoring, if you will, and letting people know that there were people present, both security and nursing staff around.
That's great. Thank you, Dr. Green. We have 5 more minutes. I think we have time for a couple more questions. Dr. Komaromy, I'm going to turn to you next to get your thoughts on vaccination, which is a hot topic and a topic of great optimism, thinking about a way out of the current crisis, in addition to all of these amazing flexible models for dealing with this second surge. Do you have thoughts about vaccinating some of these incredibly vulnerable populations we're talking about, both people who are unhoused, people with substance use disorder, mental health co-occurring disorders, and what strategies need to be thought about when we think about equity and access?
Great, thank you, Dr. Wakeman. You know, I think probably we should ask Dr. de las Nueces to comment on this afterward, because I know Boston Healthcare for the Homeless is very involved in that. But from the standpoint of the approach that we're advocating within the hospital and trying to take, is to involve members of the community that we're trying to reach in participating in making plans for how to reach that population, and also being ambassadors to reach folks who may oftentimes have justifiable concerns about the care that they're going to receive from the formal medical system, and to have trusted members who can provide reassurance, can provide testimonials based on their personal experience that they've been treated well, and the reasons why they have received vaccination, and think that it's a good idea, rather than taking what is unfortunately our usual approach as healthcare providers, which is to say we know best and we'll tell you what you need to do. So trying a little humility, hopefully will be helpful.
Great. And yeah, Dr. Denise, would love to hear your guys' thoughts as you think about the strategy.
Absolutely. So we've been planning furiously behind the scenes for the past few weeks around our vaccination efforts, and we're hoping to start vaccination efforts at all of the Boston area shelters as soon as next week. And so our approach and our strategy from the beginning of planning, even with our own vaccination efforts for staff, is acknowledging that if we approach vaccine delivery as we've done for pandemics or for public health issues past, that without an attention to people of color and to patients with limited English proficiency, that inequities may be widened, in particular inequities related to, of course, COVID. And so what we were briefly considering for some time is using a risk assessment tool in the shelter for shelter guests that factors in. It's the Johns Hopkins University of Maryland COVID-19 mortality tool. It's a validated tool. It's easily available online, and it factors in race, ethnicity, but it also factors in underlying comorbidities. It factors in geography, such as which communities have been harder hit with COVID-19. And that is a tool that we ultimately used for vaccination efforts for our staff at BHHP for lots of reasons, most importantly because the state will be granting us a good supply of vaccines, which we just learned last week, and we're so grateful to the state for that movement on the vaccine supply. We have decided to focus our efforts not on use of the risk tool for vaccination of guests in shelters, but rather on targeted messaging campaigns for people of color, for people with limited English proficiency, and ultimately also just sharing as much of the information in as we can in culturally and linguistically appropriate ways, but also not being coercive, making sure that people understand that we recognize that there are really good reasons historically for some communities to not have confidence in vaccines, not have confidence in the medical institutions, and that we are there, we will be there if and when they change their minds. Let's say if they are hesitant to accept vaccine when we give it to them, we will be there and we'll be willing to work with them and to give them the vaccine when they are ready, when they get to the yes. So that's been our approach, and we've been working really, really hard with our shelter partners on the messaging campaign, on planning, on operationalizing, and we're really excited to start this as soon as next week. So I hope that answers the question.
That's amazing. No, thank you so much. And now, as we have hit the 1:30 mark, I think unfortunately we have to wrap up. This was incredible, and I think we could probably answer questions and continue discussion for much longer. And I think just to end, if we could take a little bit of the humanity and person-centeredness of each of you and sprinkle it across everything that we do, I think we would all be in a much better place. So thank you so much for sharing your perspective. I think you all really echoed the importance of human-centered and person-centered dignified care. And I love, Dr. Green, your comment about a culture of tolerance and realizing that our goal is really just helping people with whatever goals they have around their health and their quality of life. And often that includes just helping them stay to get whatever health or other social service needs they have met. So I want to thank you guys all for joining. I'm going to turn it back over to Julie for any last closing remarks she has. And thank you for an amazing panel.
Thank you so much, Sarah, and thank you, panelists, for just a wonderful presentation. I echo Sarah's comments about, highlighting the person-centeredness of the care that you do and the intentionalness with which you put your patients first. I do think it's a testament to all of us or all of the providers in the state, and we're so lucky to have you. I want to thank the team at RIZE for making this possible, particularly Shireen Showman, who was in charge of the webinar and helped us out a lot. We will be sending a survey out later today. I hope that you'll take it to help us inform future programming. And if you have a minute, please follow us on LinkedIn or Twitter, or take a look at the information on our site at rizema.org and sign up for our newsletter so that you can stay abreast of what we're up to. So thank you again for a wonderful, wonderful presentation.